Good afternoon and welcome to this very special live event. Melanoma cancer early detection is key, courtesy of Banner MD Anderson Cancer Center. I'm Kristen Keogh, and we would also like to recognize T.W. Lewis Melanoma Center of Excellence. Our program is philanthropically funded with the support of Tom and Jan Lewis. We're so grateful. We have some of the top minds in the field joining us today. Doctors Fadi Mahmood, a medical oncologist, Dr. Jordan Abbott, a dermatologist, and Dr. Mark Gimbel, a surgical oncologist, will all be joining us. These are all fantastic doctors with Banner MD Anderson Cancer Center, and we look forward to chatting with them in just a moment. First, we do want to go over some quick housekeeping items. This is a live streaming event, so if the stream goes down at any time or you have a connection issue, we recommend just logging off and then logging back on. This event will be available to stream and then share on demand once the show is over. We will be bringing up our doctors one at a time to go over some key items related to melanoma cancer and the patient journey, and then we will have a panel discussion with all of the doctors at once. So we invite you watching at home to submit questions throughout the show using the chat feature, and we will try to get to as many of those questions as we can. We want to make this an interactive experience where you get to have your questions answered. Now let's meet our first guest today.
Hi, I'm Jordan Abbott, and I'm a dermatologist with Banner Health. Oncodermatology is a field that focuses on treating the hair, skin, and nail changes that occur during cancer therapies. Unfortunately, sometimes these side effects can be really significant, and the patient may have to pause or even stop their cancer treatment. I see patients going through all types of cancer therapies, including immunotherapy, chemotherapy, and radiation, who are having side effects in their hair, skin, and nails. We work together to develop a plan that decreases their symptoms, improves their quality of life, and ultimately allows them to continue on their cancer treatment. I would hope that every patient who sees me would say that they were listened to, that they were treated kindly, that information was explained clearly, and that they left our visit feeling hopeful.
And here she is. Joining us now is Dr. Jordan Abbott, a dermatologist with Banner MD Anderson Cancer Center. And we're going to get a little bit more information on the background, really, of understanding melanoma and what exactly it is. So let's start with defining melanoma.
Yeah, so melanoma is a type of cancer. It's actually the 5th most common cancer in the United States. Most often, melanoma starts on the skin, so we think of it as a skin cancer. And when we think about skin cancer, there's 3 main types: basal cell carcinoma, squamous cell carcinoma, and then melanoma. Melanoma is often considered the most serious type of skin cancer because if it's not detected early, it does have the potential to involve the lymph nodes or spread inside the body.
Let's go over some statistics, some of the latest information that we have about melanoma.
Yeah, so as I mentioned, melanoma is the 5th most common cancer in the United States. It is mainly a type of cancer that affects adults. The average age of diagnosis is age 65. However, it also does affect younger adults, specifically women in their 20s and 30s. It's one of the most common cancers among that demographic.
Oh, that's such good information, because I do think that we typically assume that it's older people getting melanoma. Yeah. So that's a great information to put us on alert at a younger age. And on that note, let's talk about the significance of early detection and how that can impact outcomes.
Yeah, that's a great question. Early detection is really important. We know that when melanoma is detected early, there's a 5-year survival rate of 99%. So what that means is that if it's a really early melanoma that's just on the skin surface, when it's detected, an individual with that diagnosis has a 99% chance of being alive at 5 years from their time of diagnosis.
And we're going to be taking a deeper dive later with our upcoming doctors about what happens beyond that, and it's going to really emphasize even more how critical it is to get that early detection. And that being said, let's talk about skin checks.
Yeah.
what should we be watching out for at home to start?
Yeah, that's a great question. So I'm glad you asked that. The skin check really does begin at home. So I do recommend that everyone takes the time to, on a regular basis, examine their skin all over. So you may need a little handheld mirror to see the back and the back of the neck and, you know, the undersides of the legs. You want to check the soles of your feet and in between the toes. And so you want to just become familiar with your skin, first of all, what is there and what has been there. And then over time, if you're doing this at a regular interval, say every 6 months, you can become, you know, more familiar with, is there something changing in that area? It is, you know, sometimes hard if someone has a lot of moles on their skin to remember exactly which one was where and what it looks like. So I do sometimes recommend that patients will take photos of their skin to then have as a reference point to go back and compare. Some of the things that you want to look out for is a spot that's changing. Melanoma often does start as a brown spot or a dark spot on the skin. However, it really can be pink or skin colored, so you want to be aware of anything that's new or changing. It can also be in a pre-existing mole that someone has had all their life, but now it's undergoing change. So that's why those photographs can be really helpful.
Okay, really good tips. I feel like I'm pretty good about staying on top of it because I'm outside all the time, but it never would have occurred to me that I need to be checking the soles of my feet or in between my toes. So really great information there. Now, at the point that you realize, hey, something does seem to be changing, what should you be looking for when you're going to a dermatologist?
Yeah.
We're our own best advocates.
Yeah.
We know our body's best. So what do you recommend once
Yeah.
we're at that appointment?
It's a great question. So after one has identified a spot that they think is changing or maybe is a little suspicious, is that spot new, they should seek out the care of a physician. I do recommend that they see a board certified dermatologist. They spend 12 years in training to be the experts on the skin. And so when you see a dermatologist, you want to go in for a full skin check. You know, sometimes people will say, I'm coming in just to look at this one spot, but you're kind of doing yourself a disservice if you don't take the opportunity to have your skin looked at all over.
What are the latest recommendations for how often we should be getting these skin checks?
Yeah, it's a good question. So the U.S. Preventative Task Force makes recommendations on cancer screenings and screenings for other medical conditions. They currently do not have a recommendation for skin cancer screenings because they have said that there's not enough data to make a recommendation about the risks versus benefits of doing that, but that don't want that to diminish the importance. It's really just that there haven't been studies conducted to look at that. We do know that when melanoma is diagnosed by a dermatologist, it is often diagnosed significantly earlier than when it's brought in because a patient noticed a spot on their skin. So when it's diagnosed through that skin cancer screening, it's often a much earlier melanoma.
Yeah, and especially for those of us in Arizona who are
Yeah.
outside enjoying our beautiful weather all the time, definitely want to make sure we're making those appointments for skin checks. You will have the opportunity to ask Dr. Abbott more questions. So again, if you do have anything that you want to ask her, submit it to the chat and we'll be able to hopefully bring that message back up to her during our panel discussion. Dr. Abbott, thank you so much for answering all our questions.
Thank you for having me.
All right, now we're going to go ahead and meet our next doctor.
Mark Gimbel, Surgical Oncology. One of the things that really excites me about what I do is the fact that not only do I get to operate on these really complex cases and cancers that are quite intricate, but I also get to develop a good relationship with my patients that goes on for a long period of time. I don't just operate on somebody and then don't see them anymore. I follow my patients longitudinally, where I continue to see them over months to sometimes even years, depending on the cancer that they have. And we really get to develop a strong relationship. And to me, that's probably the most powerful part of what I do on a daily basis. I would like my patients to be able to say that I was a compassionate doctor, that I listened to their fears, I listened to their wants, and then I was able to take care of them holistically. I want them also to be able to say that I was a technically fine surgeon and they did well throughout their procedures.
And now joining us live, we have Dr. Mark Gimbel, who again is a surgical oncologist with Banner MD Anderson Cancer Center. Dr. Gimbel, thank you for being here this morning.
And thank you for having me.
We really appreciate it. All right, so we talked about the skin checks with Dr. Abbott. Now, if there is the presence of melanoma, let's talk about what happens next. If surgery is needed, how do you make that determination?
So first off, patients need to go to their dermatologist. I'm going to stress that as well, to be seen and to be evaluated and get the diagnosis of melanoma. Once somebody has that diagnosis, that's when my services come into play. And what I do for patients is really dictated on how deep in the skin the melanoma grows. As Dr. Abbott said, you want to find the melanoma when it's very superficial in the skin. That way treatment's much easier. All we really need to do is excise it. But as it grows deeper into the skin, the risk of spread becomes real, and we have to assess for the risk of spread.
Now, when we get Dr. Mahmood up here, we will be digging in a little bit more into the stages of melanoma and get some deeper understanding there as far as treatment and outcomes. But for you as the surgeon, can you tell us a little bit about how those various stages are going to indicate how invasive the surgery needs to be and potentially what that recovery is going to look like?
Sure. So the surgery I need to do is based on stage, and by stage, an early stage melanoma is something that's thin into the skin. A more advanced stage melanoma means that it's thicker into the skin, but it hasn't spread. An advanced stage is when it's spread to the lymph nodes or even beyond. So the goal is to find somebody when it's in the early stage. So if I have a patient who only has a melanoma in its early stage, I can do what's termed a wide local excision. And it's called a wide excision because I just don't cut out the melanoma, I cut out a margin of normal tissue around it. The depth into the skin dictates how much normal tissue I need to take. So the thicker or the deeper the tumor grows into the skin, the wider of a margin I need to take. So someone who has a thin melanoma that's, say, less than 1 millimeter in depth, I need to take 1 centimeter of normal tissue around it. If they have a melanoma that's 2 millimeters or more into the skin, then I need to take a 2 centimeter margin of tissue around there. And you can imagine someone who has a melanoma that's the size of their thumb, and you need to do a 2 centimeter margin around that, that's a significant surgery. And then as the melanoma gets thicker, as I said, the risk of spread also increases. And so I would start to need to assess for that risk of spread.
Even with those bigger incisions, what's the recovery like? How do your patients do after these surgeries?
Surprisingly, patients do quite well, even with the bigger incisions. So when I take off a melanoma with a 2 centimeter margin, we're typically looking at a 5-inch incision. But as it gets that deep, I would also need to assess the lymph nodes. And when I make my incision for the lymph node, which is only about that big, these are much more uncomfortable than an incision like this, because typically I'm taking the nerves, and when I pull it back together, there's some soreness, but it's not painful. So patients actually do quite well, although we prefer to do smaller incisions because there's less need for plastic surgery and complex closures.
Can you dive a little deeper for us on that lymph node piece of this? Because obviously that's kind of the worst case scenario here, right? Is that you have melanoma and then it spreads to the lymph nodes. You have a much bigger issue, a much more intense surgery, as you're saying. How do you manage that? And what are those outcomes like?
Sure. Well, let's talk about the indications first. I think it's really important to understand that. So anybody who has a melanoma that's at least 0.8 millimeters into the skin, so we're talking quite a small depth, the risk of spread at that level is approximately 5%. And that risk increases as the depth increases. But we feel at a 5% threshold, that's a high enough threshold that we should start assessing for lymph nodes. So every part of the skin actually drains to a specific lymph node. And there's 1 or 2 early draining lymph nodes, which we call the sentinel lymph nodes. So there's a way to identify those lymph nodes, but if I want to assess those lymph nodes, we will take out not only the melanoma, but then those first 1 or 2 draining lymph nodes, AKA the sentinel node, to see if there's any cancer spread. I take them out not because there's cancer in them, but to assure that there's no cancer in them. So it's more of another staging technique to see if there's cancer in the lymph node. Now someone has stage 3 melanoma. If there's no cancer in the lymph node, they have either stage 2 or even stage 1 melanoma.
Okay, thanks for explaining that. That's really helpful in understanding how really all these pieces fit together in that advancement of melanoma.
And let me just add that Dr. Abbott talked about risk and reducing risk. One of the ways we assess that risk, the risk of it's going to spread, is to see if there's cancer in the lymph nodes. So by removing that lymph node, it really is a risk reduction by taking it out to make sure there's nothing there. And if there is something there, sometimes even removing that lymph node can be curative.
Well, and I'm sure that everyone who's a patient, potential patient, finds that comforting to know that you're taking that next step in keeping them safe and helping them with their recovery.
Because this is scary. Patients are scared. A diagnosis of melanoma people start to assess their mortality. Am I
Yeah.
going to die from this? And the vast majority of patients, their tumors aren't going to spread. And even if they are, with either surgery or what Dr. Mahmood will talk about, the treatments, we can even cure patients even once it has spread.
Yeah, that's really comforting. All right, well, great information. I just learned so much from that. And if you have any more questions for Dr. Gimbel, again, put them in the chat so that we can bring them up when we have all the doctors out on stage for the panel. And in the meantime, we're going to meet our next doctor.
My name is Fadi Mahmood. I am a medical oncologist specialized in the management of melanoma, sarcomas, and other skin cancers here at Banner Health. I want my patients to know that I am here for them and I will support them and take care of them throughout their cancer journey. Patients are truly the center of care at Banner Health, with their team members coming around them, providing them with the support they need. I want my patients to say that I trust this physician. He provided me with a clear answers to my question. He provided me with the best care I've possibly could get.
And now joining us live, Dr. Fadi Mahmood is here up on stage, a medical oncologist, as we mentioned. He's joining us to discuss really the state of melanoma cancer. We really appreciate you taking the time, doctor. Let's start with talking about the stages so that everybody has a clear understanding of them. And then I'd love for you to get into really how they help you determine the treatment plan and what the potential outcomes look like based on stage.
So when I meet a person or a patient with melanoma, got referred to me from Dr. Abbott and Dr. Gimbel, after they finish the surgery, the most important next step is to determine the stage of this melanoma. And the stage of the melanoma helps us in it correlates with the outcomes, and also help us decide whether a specific person with specific stage would need more treatment after surgery to decrease the risk of melanoma coming back. So for the stages of melanoma, we talk about the T, the N, and the M. The T stands for the tumor, and there are a couple of things I look in the pathology report is the depth of the melanoma, and also the outer side or the outer surface of the melanoma, whether it's eroded or not. We call it the ulceration. The N, I will look at the pathology report to see if there is any involved lymph node. And of course, the scans, a PET scan would be helpful for me, especially with high risk melanoma like 2B, 2C melanoma. Those deeper melanomas, it's important to get a PET CT scan to see if there is any M metastatic disease. So to make it simple, if there is a metastatic disease, meaning a melanoma spread to the liver, to the lung, to the bone, that's stage 4.
Okay.
If the melanoma spread to regional lymph node, let's say you've got a melanoma in the left arm and it went to the left armpit, lymph node enlarged, seen on a PET scan, here we're talking about stage 3 melanoma. Or if Dr. Gimbel did a sentinel lymph node biopsy and it showed that the melanoma, already those melanoma cells sitting in the lymph node, that's stage 3. Pretty much stage 1 and 2 melanoma, the melanoma is still in the skin, with one caveat. Sometimes we have a word called setulosis or in-transit metastatic disease. So that's immediately considered as stage 3 melanoma. Give you example about the stage, how it correlates with outcomes. If we take a stage 1 melanoma, the 10-year overall survival is 98%. You take stage 2C melanoma, this is a melanoma went a little bit deeper into the skin, more than 4 millimeter with ulceration. The 10-year overall survival, 75%. So we are losing 25% to stage 2C melanoma. So I think it's important.
Yeah.
And also it's important for the treatment.
Well, thank you so much for getting deep into that and giving us this clear foundation for understanding all of that. When it comes to treatment, can you explain any advancements in care that maybe you're potentially excited about, and how you're utilizing immunotherapy?
So, I mean, if we're going to talk about immunotherapy, I think the revolution of immunotherapy started with melanoma. If we look at stage 4 melanoma before 2011, 95% of the people with stage 4 melanoma, unfortunately, they die as a result of the disease. We really did not have a good treatment back then. We had high dose IL-2, we had some chemotherapy considered palliative, high dose IL-2. We've got 5 to 6% of the people have a long-term remission. But since 2011, we have what we call immunotherapy or checkpoint inhibitors. These are IV treatments, IV infusion, and they work on harnessing the power of our immune cells, our T cells, to fight cancer. And they are given IV. So, for example, stage 2B and 2C melanoma, we give immunotherapy for 1 year, and it decreases the risk of recurrence and death by 35%. For stages 3 and 4 melanoma, completely resected, we give immunotherapy also for 1 year to decrease the risk of recurrence, and it decreases the risk of recurrence or death by about 50%. I would also throw here the BRAF. It's important for people with stage 3 and 4 melanoma to get a gene testing to test for the BRAF. 50% of people with melanoma, they may have a BRAF mutation, and if they have that mutation, they can be candidate also for targeted therapy that also decrease the risk of recurrence by 50% in stage 3 melanoma.
Wow.
So we have a lot of options, and
Yeah.
the field is really exciting.
That's really great information. Some great improvements that you shared there right off the top. You mentioned decreasing the risk of melanoma returning. You touched on that. Can you elaborate a little bit more on some of those key factors in decreasing that risk?
So, I mean, as we said, the staging will determine, the risk of melanoma coming back. For example, stage 3 melanoma, I mean, we have 3A, 3B, 3C, and even 3D. As we go up in the stage, the risk of this melanoma coming back, it can come back locally or it can come back anywhere in the body. That's the reason it's so important to do surveillance scans and follow those patients. We typically, within the first 2 years, we do a CT of the body, total body, every 3 to 4 months for the first 2 years. And once we determine the stage, that's the importance of giving this immunotherapy drugs is really, we have found in well-designed phase 3 clinical trials that it can decrease the risk of recurrence by 50%, and that's a big deal.
Yeah, 50% is a big deal.
Yeah.
Well, fantastic information. Thank you so much. And
You're
now
welcome.
we have all of our doctors here for you to ask your questions, and we want to hear them. Keep them coming. We have a couple coming into the chat already, but again, if you're just joining us, you have the opportunity to go into the chat and ask our panel of doctors any question that you would like about melanoma. Let's start with this one. How can skin cancers present differently in people of color? Dr. Abbott, do you want to take that one?
Yeah, so this is an important question. Skin cancers in people with skin of color do present differently. We know that they often develop in non-sun exposed sites. So think that, we talked about
Yeah, which was so surprising to me. Yeah.
The toes, also, in areas under the undergarments, like the groin and such. And so it is important for people to know that, just because your skin is darker doesn't mean you can't develop skin cancer, and to still be aware of your skin and checking in those places.
Okay, you want to add to
If
that?
I can interject as well, we know that skin cancer happens because of ultraviolet radiation from the sun or tanning beds, if people decide to use tanning beds. So the more ultraviolet radiation one receives, the higher the risk there is. Now, people with darker skin actually do have a lower risk overall, but they're not immune. So people with dark skin colors, even lighter skin colors versus non-pigmented skin, the risk actually increases the lighter the skin gets, but darker pigmented skin still need to protect their skin with sunscreen and clothing as well.
Great reminder. Do you want to add anything, Dr. Mahmoud?
I would say the African Americans, especially the bottom of the feet, it's very important to look because it's very commonly they may end up having a melanoma in that area.
That's so interesting. I've never heard this in melanoma talk before, so I'm so glad that we're having this chat and learning so much.
And that's how Bob Marley died, so with a melanoma on the foot.
I had no idea. Wow, we are learning so much, and this is information that can truly save lives, you guys. So I love doing these webinars for this exact reason. All right, another question that we have coming in is, can you address the idea of stage 0 melanoma. You want to take that one, Dr. Mahmood?
Sure. Stage 0 melanoma is when we have the abnormal or the melanoma cells are in the epidermis, but they have not penetrated yet the basement membrane. Once it penetrates the basement membrane, that's an invasive melanoma. We're talking about stage 1 to stage 0 melanoma. What it requires wide local excision, and the prognosis is extremely good.
Okay.
It's also known as melanoma in situ,
Melanoma in
and that's
situ.
the same as stage 0 melanoma.
Okay. Great information. All right, we got another one coming in. Dr. Gimbel, this seems like it's going to be for you. If you take out the lymph node and later melanoma is found in the same location, how does that work is what they want to know.
Yeah, it's a challenging question, and it's a challenging situation because melanoma can always come back. It can come back in 6 months, it can come back in 5 years. And if it comes back where the lymph node was removed, that can imply a couple different factors. Either that when the melanoma was initially in the lymph node, if you had it there, it grew out of the lymph node, and we call that extracapsular extension. If there was no melanoma in the lymph node, it could also mean that the melanoma, say it was on the arm and the recurrence was in the armpit, that maybe there was a cell on the way there that just didn't make it to the lymph nodes yet. And so when it finally makes it to the lymph nodes, then someone can get melanoma there. So there's a couple factors for that, and it's hard to know exactly why that is, but even if it has recurred in the lymph nodes or in the same area, still treatments, still potentially curable as well.
Okay. Do you want to add anything to that, Dr. Mahmood? All right. Let's talk about sun exposure and some different risk factors. So let's start with, are there other risk factors other than sun exposure that we should be thinking and talking about? Do you want to take that one, Dr. Abbott?
Yeah, I can talk on some of those points. So beyond sun exposure, we know that someone's own physical features does influence their risk of developing melanoma. So individuals with really fair skin that burns easily, they're more susceptible to forming a melanoma. Also, people who have light hair and light eye colors are more susceptible to melanoma. Additionally, if someone has a lot of moles on their skin, 50 or more is kind of used as a cutoff to indicate someone who has a lot of moles or nevi, and they are at increased risk for melanoma as well.
And I know that growing up in Arizona, there was always talk that every time you got a sunburn, you were putting yourself at further risk for melanoma.
Yeah.
Is that true, that when you actually get a burn,
Yes.
you're increasing risk?
One of the largest identifiable risk factors for melanoma is the amount of severe sunburns that someone has had.
And okay, let's elaborate on that. What do you consider severe? Is that like when you're peeling or just when you're really red? What would you consider?
Yeah, so it's hard because, you know, this is subjective on what
Right.
people are going to consider as a severe sunburn. But yes, as a physician, we usually do describe it as one that's where someone is red, which often does result in peeling afterwards. Sometimes that will be called a blistering sunburn.
Oh, those are the worst.
Yeah.
You have one of those once, you never forget it. What do you want to add, Dr. Gimbel?
I just wanted to add, in terms of other risk factors for melanoma, I get a question a lot as, is it genetic? I have melanoma, my mother had melanoma.
Yeah.
Is this genetic? And I think that's a very common question that people want to know. And the answer to that is it's not clear. We know that they're genetic syndromes. Approximately 10% of melanomas have a genetic syndrome to it where there's a defect in the baseline genes. But as somebody lives in a situation where they're getting a lot of sun exposure, well, family members are getting a lot of sun exposure. So 90% of the time it's not genetic, but you will see it in multiple family members because you all have the same environmental exposure. And there are some people, just like smoking, where people could smoke their whole life and never get lung cancer. There are people who get lots of sun exposure and don't get skin cancer versus other families that do. So from a genetic standpoint, low risk, but environmentally, you would see it as a much higher risk.
Would you like to add
I would
to that?
just add the tanning beds.
Yeah.
Oh, yeah, and we actually did have a question about if it is okay, if it is safe at all to go to tanning beds.
No, not at all. I mean, I think tanning beds are considered a carcinogen.
They are,
and we should avoid them.
Okay.
They are dangerous.
Yeah, just one use of a tanning bed has been shown to increase one's risk for developing melanoma by 25%.
Oh my gosh, that's wild. All right, stick to your spray tans, everybody. They're much safer. All right, we do have another question coming in. Light eyes, we talked on that. So like you and I have light eyes. So as soon as you said that, I'm like, all right, we're in that category. So is it true that you can get skin cancer on your eyes? And is there a risk there that we need to be aware of?
Yeah, that's a good question. So people can definitely get skin cancer both around the eyelid margin, so the skin surrounding the eyes, and then the actual eye itself can develop cancer. However, when we talk about uveal melanoma, which is a melanoma in the eye, a lot of times that is thought to have more of a genetic basis. But UV exposure can certainly, be a factor in melanoma or other skin cancers that develop around the eyes and the skin.
All right, that is so interesting. Good to know. All right, blood tests such as Natera, this is our next question. Blood tests like Natera, how trustworthy of an indicator would you guys say that is? Who wants to take this one?
The blood test is
Natera?
The Natera test?
Natera?
Yeah.
I really follow, the clinical data, and I follow the stage when I determine the treatment for a person. I really don't use a Signatera. I find it's an area of research. And let me tell you what's a Signatera test. It's basically taking a blood test to look for circulating DNA of the tumor.
Okay.
The problem is, we've got 7% of people who are totally healthy. We may find some tumor cells. And what does that mean? And the test becomes really confusing. So in the area of research, I think it's fantastic, but it's not, I don't think it has a clinical utility yet in melanoma. And I would not base, the decisions about treating a person based on the Signatera test. I will go with the staging of the melanoma.
Okay.
And if I can interject,
Yeah.
Natera and the Signatera, that blood test has actually been used for a lot of cancers. And it has been well documented that it's useful in following patients, surveillance, and staging. Because so many people are diagnosed with early melanoma and the risk of risk of the cancer cells being in the blood are so low, I think the role for this within melanoma has not yet been defined. Ultimately it might, but I think it's still too early. As Dr. Mahmood said, it's still in the research phase for melanoma.
Okay, great information. Okay, we have a lot of really good questions. Please address amelanotic melanoma. I hope I'm saying that correctly. I am not the medical professional. So there's no color?
There's no color.
Okay, so that's what it means?
Yeah.
How would you find it? What are you looking for?
Yeah, and amelanotic melanoma is going to be a melanoma that is skin colored or pink. It doesn't have that pigment to it. You identify that as it's a new spot on the skin. It's one that's coming up where you didn't previously have a skin growth. I will say amelanotic melanoma is not very common.
Okay.
So as long as someone is keeping track of their own skin and then seeing a physician to get a full body skin exam, I wouldn't keep oneself up at night worrying about an amelanotic melanoma.
Okay. Anybody want to add to that one?
It's nuanced.
Okay.
Again, what Dr. Abbott said in her initial talk, though, is if you have something that's changing, whether it's pink or whether it's dark, get it checked out.
Okay. All right. Good advice. Are there vitamins or supplements that could help fight off melanoma? And then they also said, what about HelioCare?
I am not familiar with HelioCare, so I can't answer that.
I can speak to HelioCare. Okay. So we do not think of HelioCare as fighting off melanoma by any means. So HelioCare is an extract that's derived from a fern that's indigenous to South America. So that fern is using this protein to protect its leaves from the scorching sun. So it is a supplement that does have some good studies behind it showing that it decreases one's likelihood of burning with UV exposure.
Okay.
So I never recommend it in lieu of sunscreen, but it can be a good adjunct. So say, you're gonna spend the day at the beach, you're gonna try your best to reapply, but you still come out a little pink. HelioCare can be really good for adding another layer of protection. It does not fight melanoma, and I wouldn't say that it prevents melanoma.
I've actually seen those supplements at the dermatologist's office where it's a little capsule.
Yep, exactly.
They're like, take this if you're going to be spending a lot of time in the sun, but you still need the sunscreen.
Yes.
That's really interesting.
Yeah.
Anybody want to add to this?
I would say, the people who have this plastic nevi, a lot of time they have this recurrent melanomas, and they're really searching for something, supplements or something to prevent it. And this is an area of unmet need, prevention. How can we prevent this dysplastic nevi from becoming melanoma? There a lot of work has been done in the terms of vitamin D and everything, but really there's no consensus and recommendation that vitamin D can prevent melanoma. We go again with the prevention, sunscreen, avoid the sun, go to the dermatologist. If you see something abnormal, just take care of it early on, and that's the prevention we have. But hopefully in the future we'll maybe we'll have some preventive
Yeah.
medicine or
Maybe next
drug
time
that
we
can,
are sitting up here, we'll have some breaking news
But
about
certainly some
that. Wouldn't
unmet
that be
need.
great? All right, skin tags and subkeratosis development into melanoma. I'm assuming what they're asking here is that common that it develops
No.
into melanoma? Is that a risk factor?
Those are both benign skin
Okay.
lesions, skin tags, and seborrheic keratoses, and they have no potential for developing into melanoma. However, you do want to make sure that that is the diagnosis. You know, I wouldn't
Okay.
diagnose that at home. This is a seborrheic keratosis. If
Okay.
it's a spot that's suspicious, you want to see a physician
So
to have that
don't-
diagnosis.
Don't look at the spot and say, oh, I think it's just a skin tag,
Yeah.
and go on WebMD and do your own research. You want
Yeah.
to, if anything is suspicious,
If there's-
the guidance is go see your dermatologist.
Yeah.
Okay. You want to add to that at all?
There's a lot of skin lesions. People can spend years looking over the internet to figure out what
Yeah.
it is they have or what they don't have. Again, it's screening. Have someone look
Yeah.
at you. If you think there's something off, if something's changing, and I keep harping on this, go get it checked.
Yeah. And you know, I'm one of those people where I'm always out in the sun, so I go constantly anytime something pops up and I'm like, just take it off and biopsy it. But is that a good recommendation too? Like, should we just be taking them off, or should we be waiting? And what do you recommend as far as that kind of testing when you do have something suspicious?
Well, you don't need to have everything taken off, and that's why you have somebody like Dr.
Yeah.
Abbott to be able to say, this is what this should look like. She uses a specific microscope almost on the skin called a dermatoscope to actually look at the characteristics of the lesion in question. And she can actually look at it and say, benign, don't worry about
Totally
it.
fine.
And even using her naked eye, you've done this so long,
Yeah.
I don't need to speak for you, but she can identify.
Yeah, and I think for anyone who's out in the sunlight, it's, at least for me, it's just for the peace of mind of having those expert eyes on it, and then I don't have to worry about it anymore until my next skin check. All right, can you touch on itching and slow to heal sores? Are those important things to keep an eye on as a symptom? Do you want to take that one, Dr. Abbott?
Yeah, definitely. So that is often a recommendation I make to patients when looking for a skin cancer. You know, that does fall more into the category often of a basal cell or a squamous cell carcinoma as a sore that won't heal. I have so many patients who come in and ultimately get diagnosed with basal cell who said, this is a bug bite, you know, but it's been there for 2 months, but it's going away. And no, you shouldn't have a bug bite for 2 months.
Yeah.
So a sore that isn't healing in the appropriate time frame is definitely one you want to have evaluated.
Yeah, and you're your own biggest advocate in that moment,
Yep.
because it's, have you been keeping track of it? You know your body best. Yeah, that is a good reminder too. All right, please discuss how to make an appointment at your center for someone who has a diagnosis. Who wants to take that one?
I can do that. So
Okay.
the one great thing about the Cancer Center in general is we have one intake number. And that intake number, if you have a diagnosis of whatever the cancer may be, and in this case melanoma, you'll get put to the appropriate team.
Okay.
We even have a center that actually deals with some people who have suspicious findings that may not have a diagnosis or don't know how to get worked up, and that's also a service that we offer as well. But
That's
anything
fantastic.
from breast cancer to skin cancer to GI cancers, the great thing about where we are is there's a lot of resources and there's one central number. And
Love that.
Yep.
All right, thank you for answering that. Okay, next question. These are some really good questions. Can DSAP or squamous turn into melanoma, or are they completely different?
Yeah, we have
Whoever
some good
wants to
audience
take it.
members
I know,
asking
we
these
have
questions.
I'm like,
I'm impressed.
is it other doctors testing you
It's like they're
guys?
flipping
'Cause
open
these
a
questions
textbook.
are that good.
DSAP is so rare, so I'm impressed. But that is a condition where someone has these disseminated benign skin lesions called porokeratoses. And squamous cell carcinoma, you know, is something different yet. Neither of those are composed of melanocytes, which are the cells that make up a melanoma, and neither of those evolve into melanoma or have any potential for turning into melanoma. They're unrelated.
Okay. Anybody else want to add anything to that? All right. Let's talk a little bit more about prevention beyond sun screen. So, what about like the UV protective shirts and different things like that? Do you recommend any specific items, or is it just kind of right back to the basics?
Yeah, I recommend that people are keeping their skin covered in some way if they're outside. So, if that's UV protective clothing that one's wearing, some people cannot they refuse to put sunscreen on their skin.
Yeah.
Well, that's great. They can wear a long sleeve shirt and
Yeah.
keep their, upper torso covered that way. And a wide brim hat is, so important. It really offers a lot of protection for the face, the neck, the ears. Those are areas that get so much sun on a daily basis. So yes, in addition to using sunscreen, sun protective clothing can be really helpful, as well as all the accessories, your sunglasses, and then seeking shade when you're outside. So we know between 10 a.m. and about 2 or 3, the UV index is much higher. And so during that time, if you're outside, you want to identify, is there an umbrella over there? Is there an overhang that I don't have to be out in the direct sunlight? And so really trying to take that opportunity to protect yourself.
Anybody want to add anything?
Yeah, I think the key is probably a lot of our people who are watching may have children, and you're outside at their sporting events, they have soccer in the morning or what have you. I'm that dad who's carrying an umbrella. Am I embarrassed about it? Absolutely not.
Are your kids embarrassed about it? Maybe.
That's a whole different story. They're embarrassed about me anyway. So, but anything to keep the shade, and I think umbrellas, especially in the Arizona sun, it keeps you cooler.
Yeah.
And it protects you from the sun as well.
Yeah, and I have a toddler, so those hats that have the flap that goes down the back, I love those. And I just get it wet because it's cooling
Cools
him
him down.
down too. Yeah, and then when I go paddleboarding, I've got my giant wide brimmed hat. These are just the things we have to do as Arizonans. But another question that we got is when we're getting our manicures and we're putting our hands in those machines, I'm doing it every 2 weeks. Does that put me at risk for melanoma?
Yeah, so those lights that can dry the gel polish or your polish more quickly do emit UV rays. It's unclear right now. There haven't been studies done on humans to know if that's correlated to a risk of skin cancer. There was a study done where they took human cells and they put them in a petri dish and they exposed them to that UV light. And they did find that they acquired some DNA damage that did make them more susceptible to forming a skin cancer. So at this point, it's all theoretical. The cells in the petri dish are very fragile, and we know that. So right now, the recommendation is if you're going to be doing that on a regular basis, put some sunscreen on the back of your hands, or there's those gloves, if you've ever seen them, that have the
seen some ladies have those.
The fingers cut out, and so then you can, just really be exposing the area that is.
I swear I did not submit that question, but now I am going to be putting sunscreen on my hands.
Yeah.
It really just makes sense. I do it when I go outside. Why would I not do it when I'm putting my hands directly into a UV machine? Another question that we got, and you may all want to chime in on this one, is how can I better understand my own risk? And I know this is probably going to go a lot back to that. Our skin, our complexion, and some of the things that we've touched on. But just if you can reiterate for our audience what their risk, what they should be thinking about to understand it.
Yeah, so we talked about the physical features that put someone more at risk, and then also someone does know their own personal history of sun exposure. Did they spend every summer at the beach growing up? Have they used the tanning bed multiple times? So those are also things that one wants to consider. One other is that Dr. Gimbel mentioned a first-degree relative with melanoma. There is an increased risk amongst those individuals, so they are ones that should be getting their skin checked as well.
Okay.
And if you already have a history of melanoma, that you are at a higher risk of having another melanoma and other skin cancers, such as basal cell and squamous cell.
Do you want to talk a little bit about what that follow-up looks like in case we have any people watching who have had it?
I think Dr. Abbott can, follow up with a dermatologist, and then, whenever you see something abnormal, just seek the dermatology. And I think if somebody has already melanoma, probably you follow them every 3 months or 6 months. So I think that
it depends on their stage of how closely we follow them. But then, if someone has been 10 years out from their diagnosis, then the frequency does decrease.
Okay.
They're still seeing a dermatologist on a regular basis, just maybe not every 4 months.
Okay, gotcha.
And when I see a patient, even though I'm operating on it, removing their melanoma, we know that someone who has a melanoma, they have a risk of getting another melanoma somewhere between 10 to 15% in the next 2 years. So not only seeing me in follow-up, but making sure you see your dermatologist, because as we said, they don't always look the right thing, so continue that surveillance. From a surgical standpoint, what can increase risk is actually that margin status that I talked about. If we don't get wide enough around the melanoma, you can actually have an increased risk. So I'll see patients who say, hey, my dermatologist cut it out because it says the margins are negative. Do I need to do anything else? And I would say, absolutely. We know that the studies have shown that if you don't do a wider margin, you have a higher risk of it coming back. So I would even still operate on somebody despite the fact that their initial biopsy says that they got it all.
Yeah, and that really emphasizes the significance of your approach that you discussed during your portion of this and how you respond in that procedure. One of the questions that we got is, can you clarify whether the ABCDE check is accurate? Anybody want to take that one?
So that's really just a tool that one can use when we talked about performing those self-skinning exams at home. The ABCDE rule can help someone kind of walk through a lesion and determine, is this one that should be evaluated? So A stands for asymmetry, if one's half is different than the other. B would be an irregular border. C, it's talking about one specific lesion. Does it have multiple colors within it? So maybe light brown and dark brown. That could be a concerning lesion. D is a diameter greater than 6 millimeters, so greater than a pencil eraser about. And then I think the most important one is E for evolving or evolution. So a lesion that's changing. I think we've all harped on that multiple times. Is, you know, a spot that is continuing to become different than it previously was is one that you should have evaluated. So if you identify any of those characteristics, you want to make an appointment and get that spot checked out.
All right, good. We're reiterating that at the end as we're almost ready to close out. One question we got is, can melanoma be cured?
Absolutely. I think, as Dr. Mahmood has said before, it depends on the stage. Patients see Dr. Abbott early. They can be cured just with early detection and biopsy. If they see me and the tumors are early, whether it's stage 1, stage 2, or even early stage 3, by removing it, that could be curative. And even if someone has metastatic melanoma where it's spread through their body, getting immunotherapy, getting targeted therapy, we've still seen patients whose diseases have melted away and have long-term survival with no evidence of recurrence, which we would call a cure.
All right.
I agree. I mean, we have really, I mean, we're seeing people with stage 4 melanoma. They're living 13, 14 years since the introduction of the first immunotherapy. And that's really remarkable. We did not have that before 2011. People would live for about 6 months to a year and then they would die. And just seeing them 13 years after the first immunotherapy that got approved in 2011 is just a remarkable story.
Yeah. Well, thank you guys all so much for the incredible work that you are doing in improving outcomes, detecting melanoma. Before we go, is there anything that any of you want to add?
I'd like to say one last thing, if that's okay.
Yeah, go ahead. We'd love to hear it. Yeah, we'd love to hear it.
Melanoma, it's a multidisciplinary specialty where it's not just dermatology early detection, it's not just surgery, it's not just immunotherapy. It's all of us working together to manage a patient holistically, which I said in my little blurb earlier. But we understand that there's lots of ways melanoma can present. There's lots of ways to treat it. And we only touched on it on this discussion. So there's a lot more we could go into, which we won't. But I think with the team that we have here, with the T.W. Lewis Melanoma Center of Excellence, that we are ready and willing and capable of taking care of the melanoma patients.
Wonderful. You want to say anything?
Just reiterating the importance of performing those at-home skin exams and then seeing a physician on a regular basis to get your skin checked.
All right. Dr. Mahmood?
Wonderful to be part of a great team, and we're doing great things here in the Valley. And we're here to help people in the Valley and outside of the Valley too. We got some people even from outside state. We have a great program.
Yeah, I've had people in my family with melanoma, and I've seen the impacts of it and fantastic outcomes. And as someone who loves getting outside here, it's always top of mind for me. And this was a really educational, but also a really inspiring conversation, especially when you talk about these rapid improvements in this specific area of oncology. So thank you each and every one of you for just taking the time to have this conversation. And we appreciate all of you watching.
Thank you very much.
Thank you
for having us.
If you would like to learn more about the T.W. Lewis Melanoma Center of Excellence, you can click the link that's in the chat below. And if you have a skin concern, please don't hesitate to reach out to your primary care physician or your dermatologist. We know the importance of early detection, so go ahead and make that call if you are concerned at all. Again, thank you for watching and participating. You guys submitted such fantastic questions today. And as a reminder, this will be available to stream and share with those you know. So if you have anyone in your circle who you would like to share this with, you can get this really valuable information that is potentially life-saving in their hands by using the link available after the show. Again, thank you so much for watching, and we're going to see you next time.